Good morning, everyone. Welcome to the Journal Club. It's so nice to see you. I see that we have a lot of people today. Actually, it's great, and I know why, because we have a very amazing session, special session. We leave the MR world for a minute, and we have two amazing speakers. Actually, Rick Walton. Rick Walton is a researcher in Lyric in Bordeaux. You probably met him during the cardiac imaging workshop last summer. And we have Salim as well, who's gonna talk about the new CT scanner. And Salim is a radiologist working in Lyon in France at Creatis. And he's also a fellow, invited fellow in Lausanne in Switzerland.
Hello, everybody.
Just to remind you, this meeting is being recorded and will be available on the educational website of Lyric. Do not hesitate to check out the past sessions. All right, let's start. Salim, do you want to share your screen?
Sure.
Thanks so much for joining and for giving this talk on the new photon counting CT scanner. Thanks, Salim.
Okay, thank you, Aurélien. It's a great pleasure to share our experience and to share the expertise in the field of the spectral photocounting CT technology. So let's start with first principles of this technology, and then proof of evidence, and also first on preliminary or initial experience in the clinical field. So first of all, we all know that computed tomography is an excellent modality for the heart. I mean, you can do a fast acquisition with a high temporal resolution and high spatial resolution for looking at the coronary arteries, and also all the small structures the heart can show it. And even more, I mean, more and more evidence are showing that coronary CT can be first coronary CT strategy is of great interest of clinical relevance when it comes to the patient with a coronarylopathy, but not only. However, despite this very interesting evidence for coronary CTA and cardiac CT in general, there are many current conventional CT limitations that are preventing from looking into a more detailed analysis or imaging of the heart, and mainly through the spatial resolution limitation. So one can see here clearly two illustration of having a higher spatial resolution for looking even more accurately to the border or some contrast or some lesions instead of a low spatial resolution. But this spatial resolution feature is not the only limitation of conventional CT. You have to think about the conventional limitation regarding the contrast resolution. And here one can see that the eyes cannot depict any difference in terms of HU values, which is through quantitative analysis very different. So there is a lack of contrast resolution, especially in the soft tissue, but also an absence of absolute quantification, because here the on-field unity are not absolute quantitative. This, for the same object, can vary as function as the KVP, the size of the object, and many other factors that makes conventional CT not quantitative in an absolute way. This is not the only limitation, and it's clear that conventional CT cannot also differentiate and specify the contrast agent and which, I mean, contrast agent or the atom that is used for the contrast agent, such as in this phantom, where you see that there were many contrast agent-based atoms, and that cannot, of course, depict by the conventional CT. So Overall, there is no absolute quantification, no specific imaging. And even more, based on this limitation, I would say that the biotechnology, or I mean the nanobiotechnology field, has not been developed regarding this conventional CT. I mean, there is not a dedicated contrast agent for specific imaging, but more and more the field is moving and developing this new contrast agent related to the spectral photocounting CT technology. One more limitation, and it will always be the limitation of CT. I mean, X-ray, those which are which should be as low as reasonably decrease, and conventional CT is still using a lot of X-ray, if we can say that like this. So all these limitations, we should know that these limitations are partially explained by the chain detection, so the detectors that is occupying almost all the conventional CT and even more the dual energy CT system that are found in the clinical field. And the EEDs are converting indirectly the X-ray photons and losing the energy-dependent information of these photons. Recently, the photocounting detectors, which are occupying the spectral photocounting CT, have been introduced in high count rate CT systems, and these, by their architecture and design, are overcoming the many limitations we just saw. So here one can see the illustration of the energy integrating detectors. Many limitations or architectural are seen here, but I want to highlight the fact that on standard detectors, you have the interceptor gaps or the thin septa layer that is separating each detectors, and this will increase the size between each detectors and decrease the spatial resolution. The other point here is that one can see that the incoming X-ray photons will be converted here in visible light and then converting by the photodiode, which here is referring as an indirect conversion. The other limitation of conventional detectors is that the size of these detectors is around 1 millimeter square, which altogether results in a spatial resolution around 500 or 600 microns at the isocenter of the CT. So, I mean, for looking at the patient. When it comes to the photocounting, first of all, the detector, the pixel, will be much smaller than 1 millimeter square, and the surface will be even decreased by 2 times or 3 times. And the other thing really important is that one cannot see here the thin septa separating each pixel, because there is no need to protecting from propagation of the visible light from one pixel to the other pixel, because the incoming X-ray photons is directly converted into an electronic charge. So many architecture features are explaining overcoming of the limitation. First of all, the spatial resolution, and one can see here the interest for improving by 2 times, even more 3 times the spatial resolution of conventional CT. So here you see one vendor that is providing a depiction of the pair of lines in a phantom until up to 19 pair of lines per centimeter, while with conventional CT, it's clear that you cannot depict them, and you can go even higher with the photocounting CT, up to 25, 26, 27, which corresponds to a size object around 200 micron, while you can also benefit from a decrease in the dose. You see here that you can clearly see depict also the lines with even half of the dose, even up to 24 or 25. So altogether, interest for spatial resolution and also at lower dose. And here one can see the results of a second vendor or another system based on different detectors, where one can see the depiction of a pair of lines up to 28, which corresponds to the size of 178 microns. So clear evidence of spatial resolution. But it's not the only interest for this technology, because one has to know that how it works. So, I mean, the behavior of the detection of photocounting detectors is really important to understand the other technical benefits. First of all, one can see here the polychromatic X-rays from low to high keV of the photons. So the photocounting detectors, as a semiconductor, will analyze the energy of each photons. That will depend on the energy delivered and the size and the interaction with the object. Altogether, there will be a discrimination of the energy through a proportional pulse height in the ASICs that will discriminate different energy bins, or let's say energy windows, from low energy to high energy. And the number of these energy windows is dependent on the system, and the threshold of each energy bins can be set up to be more efficient as function as the contrast agent, for example, you want to look at. Anyway, the energy bins will lead to a discrimination of different energies. And based on this energy discrimination, there will be a discrimination of very low keV energy, around 20 to 25 keV, which corresponds to the electronic noise during the detection. So by this behavior, the energy window will be able to record and also to suppress in the final image this part of the noise, which is really important for increasing the contrast to noise ratio in comparison to conventional CT. So this will lead to important suppression of the electronic noise. And here one can see a comparison between conventional CT and photocounting with the same acquisition and reconstruction parameters, or at least similar. And one can see clear the more important noise, particularly in area that are suffering from X-ray, from less X-ray dose because of the liver here, and because here of the shoulder. So clearly there is also an improvement in the noise management, and also the noise performance. This is not the only thing that is helping to increase the contrast to noise ratio. There is also a better weighting of the low energy photons. So the low energy photons here are carrying the most important photoelectric effect in the image. So one can see here the dependence of the photoelectric effect and Compton effect as function of the energy. So having a better weight of the low energy photon providing by the photocounting in comparison to the energy integrating detectors in imaging will increase and provide more contrast through a better photoelectric effect weight in the image. So this also will help to increase the contrast to noise ratio altogether by decreasing suppression electric noise, by increasing the contrast through photoelectric effect, and also by increasing the spatial resolution. There is a room for improving the detection of small structures in the heart, such as the coronary calcification. And here one can see in this phantom providing calcification at 2 millimeter and 0.5 millimeter, and with a decreasing density of hydroxyapatite, one can see clearer more depiction of this calcification in comparison to similar parameters with conventional CT. And in this graph, the yellow part are the calcification only seen by the photocounting. Anyways, after explaining these technical benefits, I would say that the most groundbreaking advantage of the spectral photocounting CT will rely in the specific and the quantitative analysis of a contrast agent, of particularly a contrast agent that will have a high atomic number. And here I'm providing a simple schematic of the conventional CT that is providing that is loading all the energy dependent information of a tissue and providing one image, a conventional image with a gray value based on a gray value, while for dual energy, which is representing a technology that has at least 20 years, that has been introduced 20 years ago in the clinical field, then can provide also two information of one tissue, and this is providing, and this is overcoming this is providing some spectral discrimination, but with still limitation regarding the specific imaging of contrast agent that can only be seen through material decomposition extended to one or to two material bases. Here, one can see that each energy windows will provide one material basis, and this will lead to a material decomposition process into multiple material bases. So here I'm showing an illustration, a schematic of how it behaves with the spectral photocounting technology. On the top row, you have all the photons have been integrated, and this will result in one sinogram and one image, while when you have each energy windows, from each energy windows, you will have a singular pipeline that will result in different sinograms between water, iodine, or photoelectric encanton, and a third material basis that can be extended to a fourth or a fifth, with of course lower performances. But anyway, here there is an illustration of one basis, two bases, and three bases for the KH contribution of an atom, and this map will be the most groundbreaking feature of this technology. To understand how the impact in clinical imaging, here I'm showing a phantom. In each tube, you will find two contrast agents that have been mixed, so their attenuation, their integrated or accumulated attenuation will be the same, around 280 Hounsfield units. So here on this conventional image, no one can say that there is iodine or gadolinium, and in which quantity. While when we go through iodine image here, one can see the decreasing concentration, the clockwise decreasing concentration of iodine, while for gadolinium there was the opposite, which resulted at the end in the conventional CT, of course, but in this image, which was losing all the energy dependent information. The second result here on both iodine and gadolinium image, but with both on this spectral image, there is a total suppression, or no signal arising from the phantom, because the phantom is not, of course, made of iodine and gadolinium, and there is here a specific imaging of this image. These images are not only specific, they can provide quantitative and with high accuracy performance. And here one can see the linear regression with a very high performance for iodine and gadolinium quantification. Okay, so to sum up all the technical benefits that result in, that will be important for clinical imaging, I would say that in comparison to conventional, there is improved spatial resolution, reduction of beam hardening, electronic noise. There is a very important improvement in contrast to noise ratio, and also it's an open room for X-ray radiation and contrast agent reduction. In terms of spectral key feature, and this is really here innovative, this is more about material decomposition imaging and what we can expect from the new KH imaging method for detecting contrast media suitable for spasticity imaging, for specific and non-specific imaging, and also for looking into a simultaneous multi-agent imaging, like iodine gallium that can be, we'll see, extended to many other KH contrast agents. So about experience, the first experience in our facility started with the project, the European H 2020 lead by Professor Philippe Drake. And so it was a consortium, it was a project for cardiovascular and neurovascular imaging. The idea was to combine expertise from CT, expertise from clinical, from radiologists, and expertise from the nanobiotechnology field. Altogether, the main purpose was to synthesize contrast agents, specific contrast agents for the plaque, the atherosclerotic plaque, through many targets. So along this experience, we had the opportunity to include patients and to start the research in human in 2019. And since then, we have made great progress looking at the heart, looking at the chest, looking at the bone, the carotid, the liver, the kidney, everything, and also the bone here. So altogether, photocounting, we expect that photocounting will be for all the parts of the body, for a whole body CT imaging. So let's stick to the most important application in the world, in the human. And here I think I fully agree that the heart is the most interesting part, even if we say that brain is the most noble. Anyway, so first of all, angiography, coronary spasticity angiography. So by improving spatial resolution, by improving all the conventional picture, there is a clear evidence that we can go up to the distal vessels, looking at 500 micron coronary arteries. So here it's a comparison between photocounting and a standard CT, where we saw in this patient a clear improvement in the image quality of the aortic valve, leaflets, the left appendage, and structures. And here I'm showing a figure submitted recently, where we see the coronary arteries up to the one that will go to the atrioventricular node through the. So this is in 90% of the case. The artery that is vascularizing the nodal is coming from the right coronary arteries and will have a way through the atrial septal. So this is enable clear visualization is enabled by the improved spatial resolution. Having a better depiction or better visualization of the coronary arteries also allow to improve the stenosis quantification, and it can be improved. Also, the results can be completely changed by saying that finally it is patent, while on conventional CT sometimes you cannot say if it is patent or occlude. In that case, you would say that it might be occlude, while here in that case, you see clearly that the calcification are out of the lumen and are not resulting in a strong stenosis. So altogether, having less electronic noise, having higher spatial resolution lead to less blooming artifact, beam hardening, and altogether you decrease the blooming artifact by 30% or even more to see more the stenosis. And this has been confirmed, in a way, in a subjective way by different cardiac radiologists, where they show an improvement of the overall image quality by 57%. Overall, the diagnostic confidence by more than half of the cases, and also an improvement of the noise. While in that study, the parameters, the reconstruction parameters were of higher spatial resolution than conventional CT. And cherry, I mean, not last but the least, having also in this study X-ray seedings of 90%. So this is showing a strong improvement in terms of the coronary SPCT angiography. But let's look at other part of the heart, like the myocardium. And here one can see a patient that was that underwent the photocounting CT at the early phase of an ST elevation myocardial infarction. So this patient had a coronary angiogram that was negative. So we took this patient to the photocounting and did a first pass arterial phase. And one can see on the conventional image hypodensity, a transmural hypodensity was barely seen, while with the benefit from a spectral virtual monochromatic image at 40 kV or the iodine image. One can see clearly this hypodensity, which represented in that case non-going ischemia. And altogether, this patient, I mean, she had a second look coronary angiogram where they showed a rupture plaque. So altogether, this patient is a myocardial and myocardial infarction, non-obstructive coronary artery disease. So it also can be benefit for the myocardium, for the myocardial characterization, but also for the calcification. We saw previously in a phantom how we can increase the depiction, and this is the same. This is also working for in vivo for patients where we can clearly see two microcalcifications that was not depicted or hardly depicted on the standard CT. And about calcification, and this is one of the features we do like because this is easy to look at, and it's really in need to spatial resolution. For example, in that case, where we can see microcalcification in the trigone here, and also the distribution, the clear distribution, and sometimes the clear separation between microcalcification distributed on the aortic leaflet. So this is really interesting, as well as calcification out of the stent where we cannot clearly see on standard CT. So this calcification was out of the stent and was an obstacle or a limitation for increasing the size of the stent. You see here the deployment may be hampered with maybe also with the risk of thrombosis, second thrombosis at long term or at short, mid, or long term for this patient. What about cardiac valve? So cardiac valve is more and more an important feature and indication for cardiac CT before surgery or before treatment. So here you see the aortic leaflet, maybe with Arantius nodule, and also you can clearly see the commission part of the aortic valve, and also here the mitral apparatus with a very small feature that cannot be seen or hardly seen with the conventional CT. So it was about here conventional imaging, but like I said, cage imaging is the most groundbreaking feature of photocounting, and it will lead and it will open to the contrast agent imaging for functional imaging, for molecular imaging, for theranostic imaging, and also for cell tracking imaging. One of the limitations of KIG imaging in photocounting is that we cannot use the iodine, which is the most commonly used contrast agent for human, because of its low KIG around 33 keV. And 33 keV, there is no photon, or there is a photon starvation around this KIG. And that means that we cannot expect having KIG with this. So we have to use gadolinium or even higher Z atomic number atom. For example, in that case, using gadolinium, you can do a specific imaging of the coronary arteries, which limits or which decreases the impact of the calcification on the lumen. You can also do a specific image of the lung perfusion, the myocardial perfusion, or the angiography, using in that case hybrid nano GDF3 nanoparticle. But you can also do lung perfusion and myocardial perfusion in a quantitative way, an absolute quantitative way. In that case, one can see the myocardial perfusion with quantification of the gadolinium into milligram per milliliter units. While you can also show myocardial infarction imaging using KH for improving the quantification and the specificity, such as seen here in that rabbit model. And finally, we saw functional here and perfusion. There is also macrophage or molecular KH imaging. For example, in that case, in the atherosclerotic plaque, which was the main focus of the first European project, there was a need for improving the detection of the macrophage here that will uptake the gold nanoparticles that we used, and there was an important need for KH to decrease the impact of the calcification here in the atherosclerotic plaque to show specific imaging that resulted in a well-distributed gold in the atherosclerotic aorta. That resulted also in a better quantification of the inflammation burden represented by the macrophage, and also that resulted in a comprehensive assessment by injected simultaneously iodine into the blood pool. Altogether, the SPCT and through conventional and spectral and KH imaging mainly is completely changing the game in the conventional CT by providing evidence for aortic, for valve, for many features of the cardiac structure, which are a leverage to their implementation in clinical imaging. As a matter of fact, one can see here that the vendors here now can propose some commercially available solutions such as Siemens and Samsung only for the head, while the other have a clinical prototype ready for FDA or now soon ready for commercialization for Philips, Mars, which is only a small field of view, GE, and also Canon Medical. Okay, so thank you for your attention, and I'm open to a question.
Yes, can I start to ask a question? Thank you. Gisèle Clofan-Sanchez from CRMSB in Bordeaux. So I thank you very much for your talk. It was very interesting, and I was very interested in the nanobiologics you mentioned and the multicolor imaging, and so the European project you mentioned with Philippe Douek. Is that right? Okay, because I'm developing human antibodies against biomarkers of atheroma plaque. So your technology, of course, is of great interest for me. And when you mention nanobiologics with a European project, which kind of nanobiologic are you talking about? Do you know that? Yeah.
Yes, sure. Yeah. So we had in that consortium many partners. And we have also partners in the nanobiotechnology field outside from this H2020 that now is finished. So in this consortium, we worked with you see Frédéric Lerouge from the ENS in Lyon that's providing GDF3 nanoparticles. We worked with in this consortium with Yves Chevalier that is has designed iodinated nanoparticles, GB51. So all the nanoparticles here have been published with SPCT imaging. We are working. So I show you the gold nanoparticles. So I'm working with David Cormod. He was not in the consortium, but he's a strong collaborator. I'm working with him with the nanoparticles, but we also worked with cerium nanoparticles, and so these nanoparticles I just said are pegylated nanoparticles with a size from with a hydrodynamic diameter from 18 nanometers for the gold nanoparticles to 100 or 150 with the iodinated nanoparticles. So clearly, these nanoparticles have a strong limitation into a clinical translation. I'm working with currently under ANR. I'm working with AGIX and ELM. So we are using here a 5 nanometer or 8 nanometer nanoparticles based on gadolinium that is used in human for radiotherapy sensibilization. We have a lot more. Each partners have many nanoparticles, and recently also we started since 2 years ago a new European project which is called ScanTreat, that is using GDF3 nanoparticles or hafnium nanoparticles from the ENS that are providing theranostic properties through phototherapy dynamic induced by X-ray. So these are the nanoparticles. These are the most important collaborators. We have worked also with Giuseppe Diglio from Turin to provide GD4. This is the GD4 tetramer for increasing the concentration, because one of the main aspects we are looking for or expecting in photocounting CT is, of course, increasing the concentration of the contrast agent to improve the sensitivity of cage imaging. So we need nanoparticles with high concentration and high concentration of atoms.
Okay, because you mentioned also macrophages, and so you don't have, for example, an antibody against macrophages. That means you have macrophages that have phagocytes, gold nanoparticle. It's right?
Yes, it's a very simple. It's a phagocytosis. So this is not targeting imaging or targeting contrast agent. The nanoparticles, we show that they, of course, everybody knows that they go into the mononuclear phagocyte system, liver, spleen, lymph nodes. So in that case, they went into the macrophages, and particularly in the atherosclerotic plaque. So, and yes, so in that case, this is a non-targeting contrast agent, or I have used as a non-targeted contrast agent. Despite that, it can provide also blood pool imaging for perfusion and so on, and that we looked into that. During the age 2020, we combine the nanoparticles of Yves Chevalier, Frédéric Lerouge with TESMA and with TESMA with tropoelastine and elastine. And this, during this project, there is the team of René Botnar that have this experience of targeting the atherosclerotic plaque using GADO-TESMA. And in that case, we use a peptide and target it and put it as a surface of the nanoparticles I show in the presentation. So here we were looking into the targeting imaging, and our results that have been published in the European Union project resume, show that the sensitivity was not as sufficient as we will need for the photocounting CT, which opens with a more concentrated contrast agent and so on, and maybe a different market, different target.
Okay, so when I see multicolor imaging, as you mentioned, I thought perhaps that we can. Is it possible for you to graft antibodies to iodine or to gadolinium, and two different type of antibodies, for example, to target the plaque and see a multicolor imaging and see the plaque like that?
Yes, sure. And this is the main interest of photocounting. We believe in the team, and our research are really going to that color cage imaging. So we already have published papers looking at in vivo two different compartments, such as the peritoneal compartment with iodine and the blood with gadolinium in the same image. Also in the liver, having the arterial blood pool with gadolinium and the parenchyma with iodine. So there is clearly evidence that it works, and we can also add 2K agents. So it's not about feasibility, it's about more sensitivity. And this is where we have still development, methodological development, and also technological development to increase the sensitivity, particularly for molecular imaging.
What do you think? How do you situate your technology, for example, when comparing to PET-CT? Because for PET you can graft, of course, contrast agent like copper or something like that. Pardon, not contrast agent, excuse me, a radioisotope, and make a CT image. And what would you say about the comparison of your technology with the PET-CT?
So before getting in one detail, I would say that conventional SPCT is a one-stop shop modality. There is no doubt that PET-CT, you cannot do fast in emergency all the application of the body. So clearly, SPCT, I mean, this is a leader in terms of number of scans over the world. So there is no doubt that CT is suitable for more applications than PET-CT. Now into the detail, and it's mainly a question of sensitivity. Of course, you can see micromolar sensitivity with or microgram per milliliter with PET, while with photocounting it's milligram per milliliter. So you have 9 times lower sensitivity. So we cannot beat PET-CT on this sensitivity. So this is why there is a clearly a critical need for producing new contrast agent for this technology, and we are fully open to work with new contrast agent suitable for this technology. I mean,
perhaps I will stop my question and I will contact you later, perhaps.
Sure.
Thank you so much for your talk.
Thank you, Giselle. Thanks, Salim. I think you'll have a ton of questions. Maybe we can keep the discussion at the very end of the session, if you don't mind. Will you be available, Salim, after Rick's presentation?
I can take, I have to give a lesson to students, so I can take 15 minutes, yes. Just send me on Slack, and I will go to, it's okay, because it's an open teaching lesson, it's not, so yeah. I will take 15 minutes, okay.
Extra time, okay. Amazing, thanks, Salim. All right, so let's move on to Rick Walton. So Rick is a researcher at Lyric in Bordeaux. He's expert in optical mapping and arrhythmia. And today, Rick is going to talk about micro-CT, a different kind of scanner. So thanks, Rick, for joining the session, and the floor is yours.
Sorry, I found it. I'm here. Okay, thank you. So thanks very much. And well, Salim has really nicely introduced CT, generally speaking, and that technical discussion has made life a bit easier on my end. So I'm going to discuss more about micro-CT. So this is a slightly different scale, approaching more of scale of histology. So a system, a micro-CT system that we have in our lab is a system from Bruker. It's a benchtop system with 1276. But the fundamental way that it functions, that it works, resembles a lot of CT, classical CT at the hospital. So we have an X-ray source, an X-ray detector rotating around the sample, obtaining X-ray projections over 360 degrees or up to 360 degrees, from which we can then reconstruct tomographically in 3D the image. So the system allows for a variety of species. So the system we have is actually in vivo capable, but we're primarily using it for ex vivo imaging. And micro-CT has been used to study cardiac anatomy in a variety of species, from rat hearts. So here images of whole rat hearts. This is images that we've taken in our lab with 3D reconstructions. So you can see the amount of microstructural detail that we can observe including cleavage planes within the myocardium, vasculature, etc., within the rat heart. So these images are around 12 micron resolution. And other groups have also studied, for example, the conduction system, the Purkinje network, which has been stained by filling the cavities with iodine contrast agents to more selectively stain the conduction system. And this could then be segmented to describe the architecture of the Purkinje network. And also offcuts from large hearts, so human atrial samples, for example, have been imaged, and we've also done some atrial imaging to look at septopulmonary bundles and the epicardial surface of human left atria. And so the overall message is that micro-CT thus far has been really focused on small samples. And this is because of the limitations of the system using this standard approach of using contrast agents in order to enhance the X-ray absorbance of tissues within the dynamic range of the system. This is another sample just to demonstrate the level of detail that we can observe. This is from a sheep right ventricle, 1 centimeter cube sample. We can see a Purkinje fiber that was running on the endocardial surface here. And as the volume builds back up, you will see the trajectory of that Purkinje fiber diving into the tissue and branching within the myocardium itself. We also note quite clearly here the individual muscle fiber orientation that we can observe from throughout the volume. Here we can see the Purkinje fiber just diving into the tissue, and when you can take time to look through the volume carefully, you can even observe branching of this individual Purkinje fiber within the tissue itself. So micro-CT can really offer cellular organization at the tissue level information. So X-ray absorption, what is actually underlining this? Well, Salim has already nicely introduced this to some extent, but I'll just recap in order to introduce the next upcoming slides. Essentially, the X-rays produced within a vacuum cathode. A voltage gradient is applied, which determines the maximum energy of the system, creating acceleration of electrons towards a tungsten plate, which is actually the anode. And X-ray photons are then released after interacting with this with tungsten. The X-rays that are released, however, are polychromatic, and this we saw clearly in the previous presentation. And the reason for this is that as the electrons interact with the tungsten anode, electrons are passing through and being decelerated by the tungsten atoms, and this is depending on their proximity to the nuclei. This deceleration changes their orientation, and energy is released in the form of X-ray photons. And this is variable. The amount of energy released or converted into X-rays is dependent on this proximity to the nucleus here, which explains why we have a polychromatic spectrum of X-ray energies being released through the system. Now, the spectrum can in some ways be manipulated, especially and most obviously, let's say, by varying the voltage that is applied across the gradient. So we can define the upper limit. The maximum voltage applied describes the maximum energy that can be transferred into X-ray photons. So we can see an upper limit here of the spectrum, which is highly dependent on the kilovolts that are implemented to generate the X-ray photons. So with soft tissues, of course, we generally need to add contrast agents in order to observe them and distinguish them from surrounding medium and from other tissues such as bone, which obviously has its own absorbance, and any metallic implanted objects, for example. X-ray absorption, which is the key property here we need to understand, is dependent on not only the density and composition of the sample, but the sample thickness. And these all underlie an X-ray attenuation coefficient. And this coefficient is exponential. So as density or composition changes, this has an exponential impact on X-ray absorbance, and also the sample thickness. This is the total path length that the X-rays are penetrating through the tissue. This also has an exponential impact, which goes to explain why micro-CT imaging thus far has been primarily focused on small samples, as I mentioned, right heart samples or offcuts from larger hearts. So normally we enhance contrast with contrast agents, and the atomic number is lending to the attenuation coefficient of the product. So heavier metals have higher atomic numbers indicates increased attenuation of X-rays. So if we try to pursue a conventional approach to treat large mammalian hearts, as our interest is really in translational samples, so large mammalian heart models, such as pig, sheep, and even treating human heart samples themselves, we would like to observe really an ensemble whole heart structural image, rather than relying on only small sections. So we want to have an overall ensemble view at this microstructural resolution. So when we attempt to use contrast agents to enhance contrast of the soft tissue and distinguish it from some immersion media that we have to immerse the heart sample in, so that over the course of the acquisition, there is no deformation, no drying of the tissue, which causes it to deform during the imaging. We need to add contrast agents such as typically iodine is a common one in the form of Lugols. This is a mixture of iodine and potassium iodide, which is very commonly used in the ex vivo micro-CT setting. This here is a pig heart that we put in the scanner. On observing it from all angles, we can see that, well, the heart sample is there, but it's very difficult to distinguish from just this X-ray projection any anatomical details. Which way up is the heart? Can we observe evidence of the cavities, etc., major anatomical markers? And simply from this X-ray projection images, no matter which angle that we observe the heart from, there is no specific contrast within the image. So if you have no contrast at this stage, a reconstruction will not give you any more information than what you're observing here. And just to put this into context, if we apply the same tissue processing to a small sample, such as a rat heart, the differences are quite striking. So this is what we would expect in a small heart using the same preparation. So iodine contrast enhancement. Here we can observe cavities, the right ventricle, left ventricle, papillary muscle, even some details, some texture in the image within the wall of the ventricles, indicating some muscle fiber orientation in there. That is totally absent due to this large size of the heart, impacting which is over attenuating the X-ray image. So our aim is to adapt and integrate whole organ imaging with microscale resolution. And so we put the hypothesis that if we can optimize the imaging conditions by stabilizing cardiac tissue in air, then we would reduce the X-ray absorption. We won't have the immersion media also impacting our X-ray attenuation. And therefore we can utilize resolutions of 10 to 20 micrometers in large mammalian hearts. So our approach to overcome this was to find a novel tissue pretreatment procedure where we can stabilize the tissue structure in air. And the way that we do this is, first of all, removing all calcium from the heart, just rinsing the heart, removing the calcium with calcium buffer EDTA. This prevents any overcontraction and constriction of vasculature. We maintain a low perfusion resistance and a homogeneous perfusion resistance throughout the heart sample. We can then briefly fix the sample using formaldehyde or paraformaldehyde. And then we dehydrate the sample from serial dehydration from 30% up to 100% ethanol. And then we can treat the tissue with this chemical HMDS. This is hexamethyl disilazane. And this chemical is highly reactive with water, so it must be in 100% ethanol. Otherwise, you get some exothermic reactions. So this is why we must first dehydrate. But this chemical forms essentially a silicone backbone, silicone scaffolding of the myocardium, strengthening, reinforcing the tissue. And it's reinforced sufficiently that we can then leave the heart just hanging in air to completely dry, desiccate over a period of a week, slowly evaporating the liquid away and reducing, therefore, largely the density of the sample. With no water content in the sample at all, we now have tissue which is stable, structurally stable in air, and therefore we can image it directly in air, and we'll have optimized contrast conditions where the lowest absorbing, X-ray absorbing environment that we can have is obviously air, and then we have our tissue next to this. So we don't have to compete with water or ethanol that we are immersing our tissue in order to have optimal contrast. The resulting X-ray projections are shown here in the same configuration from multiple angles, the same heart. We clearly see something resembling much closer to what we observed in small hearts that we saw previously. So I should say that this is a pig heart that we have treated here. So we can say that we can see that the overall structure of the heart is conserved, the overall size of the heart is conserved, and we can observe cavities, some texture within the walls, and endocavity structures within just the X-ray projection. So just to clarify what is changing here, well, essentially we have an X-ray projection profile through that has to travel all the way through the sample here in a conventional setting where we have a liquid outside of the heart and the cavities that is preventing the heart from drying during the long acquisitions. For this resolution, we need acquisitions of several hours, some the 24-hour acquisitions. So drying is and changing morphology, deformation during acquisition is a real risk. So we immerse it in liquid. The problem is that the tissue is also loaded with contrast agents at this stage, and the contrast agents have a tendency to leak out of the tissue and diluting into the immersion medium surrounding the heart. And this ends up competing then in terms of contrast with the tissue itself. Given that the overall thickness of the tissue is very important now, the overall X-ray that is transmitted is very low. And this explains the low contrast that we have in our image. In comparison, what we have with our novel air drying approach is that now the heart's just sitting clearly in air, and also the tissue density is very low. And there's actually no contrast agent in these samples. And in the previous image that you saw, we go immediately from the air dried state to imaging it. And because the background is now just air, even the soft tissue is perceivable within the X-ray projection. And the tissue itself is interspersed with gaps of air between each muscle fiber. The ethanol treatment does lend to some level of cell shrinkage, but this just increases the gaps between individual muscle fibers. And the advantage is that now we have air gaps in between our fibers that simply adds to improving the contrast and resolving individual muscle fibers within the tissue. I should say that the HMDS chemical that we use to strengthen and reinforce the tissue has a silicone scaffold. And this may serve as a low-weighted contrast agent that's staining the tissue, although the atomic number of silicone, compared to iodine, which is 53, silicone is only 14, which is a very low atomic number. But given the size of the tissue sample, it perhaps has some contribution to enhancing signal within the sample. The advantage is that in order to have an optimal dynamic range on the X-ray projection, we no longer need such high X-ray energies. The advantage of that is that we can image the heart at higher resolution. As you increase the energy, the spot size, the effective spot size and effective resolution of the image deteriorates. But low energy imaging means we can go to higher resolution. So we could, at this scale of a heart sample, which is of the order of 7 centimeters, 8 centimeters in diameter, we can do 10 micrometer resolution imaging. So to compare a conventional iodine-treated heart versus an air-dried heart, how does this look when we actually reconstruct the images? In iodine treatment, we can see in red here, we've used a very simple thresholding approach just to compare the two modalities. So the histogram of the two images are shown on the right. We have a background population and a tissue-specific population. In the iodine red trace, we've taken simply the minimum between the two populations as a thresholding point, and to see what this gives us in a very simple way to separate background from tissue. And in doing so, we do not separate the immersion medium from the tissue. Even the cavity itself is poorly segmented, and the overall anatomical shape of the heart is very poorly represented in this. A volume rendering of this shows that due to the cavity segmentation being poor, this masks and disguises any deeper levels as clouds. Essentially, it acts as a cloud, making a foggy image, showing that we cannot observe increased depths and resolve the three-dimensionality of the volume. However, with our air-dried approach, a single threshold to segment between the tissue population and background population, given that now the tissue is simply air, or the image is either air or tissue, we now have a far improved segmentation. Cavities can be observed, even cleavage planes and vasculature around the epicardium can be clearly observed too. And the 3D volume rendering lends to a much clearer three-dimensional representation of a microstructural detail. So we've applied this to different applications, including myocardial infarction. This is a model that we've recently set up here, and other teams are also benefiting from the model, including Orion, who also is using MRI on these hearts, on these sheep. So this is a chronic model of myocardial infarction using a Boston Scientific embolization coils, shown here, and a single coil is implanted into a coronary vessel of choice that we can target locally and precisely, deploy a coil in the coronary vasculature, and after about 15 minutes, we see occlusion of this vessel, which leads to myocardial infarction over a period of about 6 weeks. We bring the animal back to observe the level of scar, explant the heart, and do ex vivo and in vitro measurements on the heart at this stage. We can see that under angiography, we guide and the placement of these coils. The coil can be observed here. Immediately after, there is perfusion is maintained, but after about 15 minutes, this perfusion will be lost here as the occlusion occurs. And we have ST segment elevation, indicating ischemic insult in the heart. Micro-CT imaging of these hearts after air drying reveals these sort of images. We have observed dense scar regions and a much looser border zone region, as well as the healthy tissue with organized muscle fibers. Each image increases from the apex up to the coil itself. This artifact is coming from the metallic coil placed within the vasculature, and so we can see the transition throughout the volume in these slices. So we observe a lot of heterogeneity within the sample, and here we can distinguish a lot of the morphological components of the dense scar regions, and different aspects of the tissue. However, although there is obviously with dense scar, we can see a higher attenuation regions, but within the rest of the scar, it is difficult to observe or distinguish the different compositional characteristics of the tissue within the scar. For example, if there are any surviving tissue, these fibers here, are they surviving myocardium? Is it fibrosis? Presumably surrounding fat deposits in the black regions within the tissue. But the dynamic range is low within the tissue itself to be able to distinguish the different tissue components. So we have since then designed a protocol where we combine the air drying approach with contrast agent loading. And what we observed actually is using now a different contrast agent, phospholipid acid. So molybdenum here is now the element which is responsible for the attenuation in this contrast agent. Appears to have some selectivity for annotate anatomical landmarks within the tissue. Particularly, we see around the epicardial layer, more like the epithelium, and some signs of endothelium, but not really directly on the endothelium, actually subsurface on the endocardium. There are regions of high contrast, suggesting they are linked to a specific anatomical landmark. And this initially, to us, reflected the placement or position of the Purkinje network within the heart. More likely the collagen sheath surrounding the Purkinje fibers. And this would be in keeping with an enhanced epithelial contrast also observed around the edge of the tissue. So we investigated this further in a histological setting, just a tissue slice section. Here, just through Massen's trichrome to identify the different components, so muscle in pink and collagen in green or blue, shown at the bottom here and also near the epicardial layer. So this is a transmural cut endothelium here, and this is actually the insertion of the Purkinje fiber. We took adjacent tissue slices that patient cuts there with no staining versus 2 days treatment with PMA at 1%. Exactly the same contrast agent conditions we use to treat our tissue for micro-CT imaging. And we see selective enhancement of the collagen sheath surrounding the Purkinje network, and some enhancement also where we observe collagen on the epicardial, towards the epicardium, subepicardial regions. Particularly focusing on the denser collagen at the bottom of the Purkinje fiber here, which are blown up in these images, we can see that under fluorescence also we observe collagen when there is no phospholipid acid staining. However, it is known that PMA, this contrast agent, actually reduces autofluorescence of tissue. So we can see that after the PMA treatment, there's now a total loss of autofluorescence within the tissue, suggesting that there is a selective accumulation of PMA at the within the collagen regions, the collagen sheath specifically of the Purkinje network, and also within the vasculature walls, the vascular walls that we observed near the epicardium. So there appears to be a selectivity for PMA at collagen-rich landmarks. Now, in comparison with histology, we would really now like to understand better the composition and use to determine if with micro-CT we can differentiate the different compositional components of the myocardial infarction substrate. And here is an example, a histological example that just describes what we observed, because particularly interesting within the scar region here, there is a large fibrotic component in blue, and towards the end epicardial layer, a more fat, a higher contribution of fats in this particular slice. But what we do consistently see in this model is surviving myocardium close to the endothelial layer. And this is actually stretching all the way across the scar tissue. We've confirmed with optical mapping, this is functional measurements, that we conserve functionality across the tissue. We can stimulate in the middle of the scar and initiate electrical propagation, which reaches the healthy myocardium. So this is surviving and viable myocardium within the tissue. And it's so the next target, something that we will try to separate, see if we can separate under micro CT in upcoming studies. Interesting, we also have a high amount of Purkinje fibers that survive within the infarction, and this is well described within the literature due to their capacity to their own glycolytic stores, which maintain metabolic status of the Purkinje fibers following ischemic insults. And it's likely the surviving myocardium is due to diffusion loading from the cavity itself, suggesting why only very near surface tissue survives. So in terms of structural pathology, well, as I've shown you, a myocardial infarction model has now been used. We've now shown selective targeting of collagen-rich regions, and we've also applied this. We're starting working in the context of atrial fibrillation, also in a sheep model of AF. This is persistent AF in the unmasked program here. And micro-CT images of these tissue samples that have also been treated with the contrast agent, we observe a high degree of selective contrast within the appendages of the atria. We see the appendage-free walls of the atria, left and right atria. And if we compare those with the ventricular tissue below, where there is not thought to be any high degree of pathology onset within the ventricles, we have a much lower contrast in this section, suggesting that there is selective fibrotic accumulation or collagen accumulation within the atrial compartments, which is consistent with, of course, the pathology that has been induced. So I will just finish there to say that we use microstructural imaging of whole organs from large mammals by air drying the tissue using HMBS. And so we can reduce high X-ray power, and we can optimize X-ray attenuation within the tissue. And even in the absence of contrast agents, tissue segmentation is considerably improved. But we can optimize selective collagen-enhanced images with a PMA staining, contrast agent staining, in combination with the air drying approach. Okay, and I'll finish there. Thank you. Have any questions?
Thanks, Rick. Thanks so much. Very impressive presentation and images. I think the room is open for discussion. Do we have any question for Salim and Henrik? Salim, are you still around, by the way? Probably not.
Yes, I am.
Yes, he's back. I have a couple of questions for both. Can I shoot?
Go for it.
Okay. So maybe I will start with Salim. So Salim, I'm struggling to find immediate clinical applications in our specific fields of arrhythmias. So for sure, this improved resolution will be very interesting to us to study in details the trabeculations, the free-running Purkinje, also to assess perforating vessels to reach deep intramural substrates, or also to assess small vessels. You know that we are targeting the vein of Marshall in AFib, and I guess the current technology is struggling to see it. I think we will have a better understanding with that. But now for the assessment of the arrhythmogenic substrate itself within the myocardium, I guess for fatty substrates, it should be directly improved both on the atrium and the ventricles. But for the fibrosis, what would be your recommendation? Meaning without waiting for specific contrast agents, with the currently approved contrast agents, do you think that the dose of gadolinium to load the myocardium to perform CT would be acceptable, or would you go for late iodine? What would be your recommendation?
Okay, thanks, Hubert. So clearly the morphological information that you can expect from photo counting will be much improved. So I will go further in the simply way with the thickening of the wall or the morphological information. Regarding the late enhancement that you can expect from iodine and gadolinium, there will be, of course, an improved contrast to noise ratio of this late enhancement, but I don't think it will be dramatically improved in comparison to conventional CT. I mean, you know better than me that these lesions are not fibrotic lesions, so the enhancement is low. It's not a very strong target in terms of enhancement. So that's why I may think that it's not. It might be a complicated task. I mean, very simply. Yes, very complicated task to expect C enhancement from iodine and gadolinium. Using gadolinium with CT, it's of course possible, but it's around 40 or 80 milliliter for a patient, and this I don't think will show enhancement visible on photo counting CT.
Yeah, thanks. Yeah.
For acute enhancement of acute disease, why not? Of course, I mean but for fibrosis in left auricle or so on, this has I mean, before enhancement, you have maybe thickness, you have maybe things you can improve using the spatial resolution. Yeah.
Get it. Okay, thanks, Salim. So now one to Rick. Does a whole human heart fits in your system?
Yes, we have done this. It's not all hearts. Some hearts really are too big. We have a maximum diameter of 7.2 centimeters to work with. So in some cases, we for example will cut off the atria and image those separately, for example. But in that case, it involves cutting somewhere. So either we compromise slightly the base of the ventricles or the atria, depending on which sample that we want to focus on.
And now about the image that you show of in the infarct model, I saw that there was much more air in the border zone area than in the dense scar area. Is there any reason for that? And do you have any comparison to gross pathology in different animals? Because I guess you can't use the same animal. And do you think this will limit our analysis of tissue architecture in the border zone?
Yeah, it's true that in this particular example, so the air gaps are likely to be where we have fat deposits in the tissue. So the histology I showed, afterwards you can see a large component which is fat within the model. In the histology example, it was primarily subepicardial and much more dense fibrosis on the subendocardial regions. But I find this is quite variable between the hearts. The distribution can't necessarily be preempted beforehand. There's always a good mix of fibrosis versus fat within the tissue. We need to do now more clear. So I didn't mention this, but actually one advantage of the air drying approach is that the tissue preparation that we do is actually pretty much the same preparation you would do for histology also. So after the heart has gone into micro CT, it can actually, you just cut away a section, a region of interest, and you can immerse that tissue section straight into paraffin and do histological sectioning on the same tissue. So you can have sliced matched comparisons between histology and the micro CT imaging. We've just submitted a grant application to work on machine learning approaches in order to take the micro CT images and to learn how to segment them in a tissue specific or tissue composition specific way by using this histological comparison as a ground truth for training the algorithm. So this is some long-term goals, and this is something we would like to pursue and some funding.
Oh, this is great. This is great. Yeah, thanks.
I'll jump in with a very naive question, Rick. When you dry your heart, do you feel like you're losing some kind of information since you have no more water content?
I say, well, I think particularly with the fat, it's variable, it seems, if it's dissolving away or not. I'm not fully got down to understanding, because fat can also be very variable. We generalize fat, but actually its composition is quite different, depending on pathological states. If it's just endogenous fat, epicardial fat versus, you know, accumulative fat deposited within the middle of a tissue, it's all very different. And I feel like certain fats will behave differently to others to the treatment. Some are conserved. For example, in AF sheep that we've dried, the epicardial fat was maintained. And in these images, we see a very homogeneous staining in this epicardial fat. So the texture there is very different to the texture of this striated myocardial appearance that we get. The muscle itself does not seem to be affected. It's the overall fiber orientation. We have some images where we illustrate that the overall fiber orientation transmurally, for example, is conserved. So we still have the same rotation, 120 degrees from epi to endo in the sample. Overall morphology, we don't feel like that the muscle is being impacted greatly, which is of course a relief. The overall scar tissue is difficult to work with in the air drying approach, however, because the tissue is so thin, and particularly that when it has a high fat content, it's relatively, it's not very rigid anymore, and it's quite easily deformed from the air drying process. So we'd probably need to fill a cavity with a balloon or something in order to maintain a nice shape. Otherwise, that has tendency to collapse on itself during the drying. The reinforcement's not as adequate. So these are, for me, the more important questions about surviving the drying process.
I see. Any more questions for Rick? Salim, since you're around, I've got a question for you that you might like. What's the cost of your system, and what's the carbon footprint?
So right now, the system we use cannot be buy, so there is no cost. Okay, so but I mean, there is one vendor, Siemens, that is providing a commercial photo complexity, and I cannot say the exact amount. It might be between 3 and, I don't know, 3 million and so on. Yeah, it's 3 times more than a conventional CT, we can say like that, but it's bringing you 3 times more special resolution. So no, but I would say that it's too early to set a fixed price. I mean, there is only one vendor with a wide bore photo counting CT. So let's see the other vendors. They are all in the run, so we'll see how much it will cost.
Mm-hmm.
Yeah.
Okay. There is a question from Lausanne.
Yes, can you hear us?
Yes, we can.
Okay, I have a question for both actually. You know, CT has made staggering process, right? When I started with MRI, nobody looked at CT because it just didn't work, and then it really, due to the technology that you know developed so quickly, it basically overtook MRI in many areas, and the radiation dose is going down, etc., etc. It's kind of frustrating, to be honest, as an MRI person. But when I'm looking at this and I'm thinking about Richard, you know, has this super high resolution on the one hand, and then Salim, you know, has this again new technology at his fingertips on the other hand. I wonder, Richard, do you see a future in micro CT being combined with multispectral? Is it going to go in that direction or not?
Yes, I mean, after seeing Simon's presentation, I definitely see advantages from that, and maybe especially for, as I was mentioning, really having an improved dynamic range to differentiate the different compositional components of the tissue. If photon counting can improve that in some way, that would be highly beneficial. So yeah, certainly interesting to combine the approaches. I don't know to what extent it's already being done at the micro CT scale, but yeah, maybe Salim has a comment on that.
Yes, so it's a good idea. I mean, to combine photocounting and micro CT, and I mean, one of the leaders here is the Mars project. So it's a New Zealand project, an important consortium. So they came with a commercially, it's not commercial yet, but they came with a solution. It's not FDA approved or cleared, but it might be in the upcoming or year, I don't know, but it's yeah, micro CT with new photocounting detectors is I would say this is a new trend, and this is the same for also other X-ray systems. And I'm thinking about mammography. Mammography now it's more and more occupied with photocounting. So I would say that the trend in the future, in the next years, will be to replace all the detectors with photocounting in X-ray CT systems, and bring spectral analysis, like Richard said, bring spectral capabilities. Yeah.
I have another question for Salim. For the detection of coronary artery disease, if you look at the recommendation papers, a certain pre-test likelihood for coronary artery disease is recommended for the patients to be submitted to CT, right? So meaning it's predominantly younger patients with perhaps lower risk for calcifications that should undergo CT. Because calcium leads to some luminal artifacts, which makes the detection of stenosis a little bit more challenging. Now, however, when looking at your results, it seems to me this might be solved, meaning that it could be that the guidelines will change so that the only technique left will be multispectral CT for the coronaries. Can you comment on that?
Yes, I fully agree. I fully agree that I mean, even now, more than 50% of the coronary angiogram are negative. That means that there is a way to improve the imaging before, or improve the management of this patient by providing more accurate assessment of the coronary stenosis. So right now, cardiac CT, coronary CT is for ruling out the coronary artery disease, and for ruling in, it's also relevant, as we saw in discharge trial, but it will be more and more relevant for decreasing the number of negative coronary angiograms. So we can expect coronary CT with conventional CT to extend it also the indication, but with photocounting to extend even in a more magnitude, and and will change completely the guidelines and the patient care management.
Well, you know, I think Matthias was referring, not comparing coronary angio with CT, but perfusion CMR versus CT. And it's true that that the trend is, or if you look at the guidelines in the UK, for instance, you know, there's no room for another modality than CT in the first line, and this was before photon counting CT. So we're getting there, I think.
Salim, maybe one question again, Naif. Can you make us cry and give us the scan time of your angiographic images?
No, I don't think so. It's scan time. So resolution, the temporal resolution is 150 milliseconds, because it's the rotation time of the tube is 330 milliseconds, and you acquire data the 100 degree of the X-ray rotation. So it's about 150 milliseconds temporal resolution. Mm-hmm. And you can hear it.
Mm-hmm. And just so you know, the system that is going to be installed at Lyric has the same temporal resolution as their current dual source force system, which is lower. It's around 70 milliseconds.
Yeah.
All right. Any more questions? no more. So thanks again, Salim and Rick. That was really amazing. And that was actually the last Journal Club session of the year. I think we had stunning talks this year. But don't worry, we'll be back in 2023 with more presentations. So enjoy Christmas with your family, everyone. And we'll meet again next year.